All right, well, if we're on, I thought I'd explain to you a little bit about the APTT, which is the most commonly used blood clotting test. It stands for Activated Partial Thromboplastin Time. A lot of people won't think the activators is not necessary, but in fact there are versions of the test which are not activated, such as the non-activated PTT, but I won't go into that. The APTT has got quite a long history. It was developed around about the 1950s in its final form, but before that there were a lot of improvements to blood clotting tests, and it all stems from the whole blood clotting time, which was the original test that doctors used to collect blood, and they used to collect it in a glass tube, and they noticed that if the blood took a long time to clot in the tube, the patient was more likely to have a bleeding problem in their history than someone whose blood clotted in maybe 15 minutes in a tube. The whole blood clotting time became a lot better when people found you could collect blood on citrate, and it could remain anticoagulated for quite a long time after being collected from a vein. And that clotting time was simply carried out by mixing a sample of the citrated whole blood with some calcium chloride solution, and it became a lot more reproducible. But then people started noticing funny things, like if the tube had been waxed, for example, the whole blood clotting time took a lot longer than it was just glass. So people recognised that the glass itself had a procoagulant activity on whole blood. So then you started using the centrifuges to separate whole blood into plasma and red cells. And of course they noticed that all the clotting factors were actually in the plasma, not in the red cells. So everyone then focused on testing plasma rather than whole blood. And this test was called the plasma recalcification clotting time. It was then recognised that platelets had an important role in the clotting time test as well. And people investigated phospholipids. They were the most active component of platelets. There was a deviation at that time, this was about the 1935, when Aman Quick in the US found that blood could clot extremely fast if he used a brain extract which contained a compound called thromboplastin. That's where that term comes from. Thromboplastin was originally rabbit brain or human brain extract, which helped clot blood very, very quickly. Anyway, that's for another day. The APTT people, they didn't use the whole thromboplastin, they used the partial thromboplastin, which was the phospholipid component from brain extracts. And it was found that phospholipids in general had procoagulant activity, so they were mixed with the plasma in the clotting time test. So we've got these two additives, which are the components of the APTT. There's phospholipid, and there is a contact activator. And these days, these are combined in a reagent. The contact activator, it was originally powdered glass because that had a large surface area and it was available. Then silica suspension came to be used. Colloidal silica was a contact activator. And these days, ellagic acid, or rather its metal salts, is a very popular contact activator as well. There are other compounds. In fact, most denatured proteins are now found to have some contact activity, and this is quite important in the current thinking of the clotting mechanism. The phospholipid is also very important. The phospholipid originally was a crude biological material obtained from rabbit brain or human brain. More recently, synthetic phospholipids are used, and most of these contain phosphatidylserine, which turns out to be the most active synthetic phospholipid. Although it doesn't work by itself, it needs other phospholipids in it. Pure phosphatidylserine has got very little procoagulant activity. So that's what's in an APTT reagent. You have contact activators, phospholipids. I should say that the commercial APTTs out there are very different to the original APTT. I should say credit for the APTT is usually given to Proctor and Rappaport. They were widely quoted in every paper that mentioned an APTT, but more recently their name seems to have disappeared. It's been too long. But there were many people involved in developing the APTT, including, I think, Brinkhouse's group at Chapel Hill in the US had a primitive form of an APTT. Joel Margolis from Australia, he also was the one who used kaolin suspensions in the first place to develop a test that was called the PTTK, the K standing for kaolin, and the PTT, of course, being partial thromboplastin, the phospholipid bit. So, what's the APTT good for? Well, people found originally that it was good for detecting factor deficiencies, such as in haemophilia, so it was widely used for that purpose. Then, when heparin came into clinical use as an antithrombotic agent, it was found that the APTT was quite sensitive to heparin, and clinical studies showed that a prolongation of the APTT from 1.5 times its normal value of about 35 seconds to 2.5 times that value, which is about 75 seconds, was ideal for maintaining heparin therapy with some degree of clinical safety. So APTT was used then for heparin. Then people started noticing these funny inhibitors occurring in blood. A lot of them are now called lupus anticoagulants. And lupus anticoagulants interfered with the APTT test. The APTT was used for detecting lupus anticoagulants until people realised that the lupus anticoagulants could be overcome by increasing the amount of phospholipid in the reagent. And that gave rise to two types of APTT reagents, LA-sensitive ones, which contain a low amount of phospholipid, and those which contain a high amount of phospholipid, which were resistant to lupus anticoagulant. So that introduced two variations in the APTT. The APTT was also used for measuring APC resistance. Factor V Leiden occurs in 5% of the population. The prolongation in the APTT, which was produced by activated protein C, could be used to measure this APC resistance, which turned out to be due to factor V Leiden, a genetic abnormality, which is associated with thrombosis. So the APTT was used for measuring APC resistance, and it still is used for that purpose. In more recent years, the antithrombotic agents which are available have changed quite a lot. Low molecular weight heparin, which is very effective clinically, is not readily detectable with conventional APTT tests. It's more sensitive to the high molecular weight forms of heparin, which are those involved with inhibiting thrombin rather than factor Xa. So APTT was also found to be affected by the new NOACs, or direct oral anticoagulants, or DOACs as they're now known. All of the DOACs have an effect on the APTT, but in a very different manner to the effect of heparin. Argatroban can also be measured with the APTT. So these are the most common things which affect the APTT. It's still a very widely used test for screening, but these days, because there are so many agents which can affect APTT, it's worth knowing what the effect of these is on your APTT reagent. And here at Haemotex, we're going to prepare a profile showing the effect of all of these different agents on our APT, and also in comparison with others, so that laboratories can choose what they want. We know a lot about the APTT and how it's affected, but still, in the coagulation laboratories, you're often confronted by an unexpectedly prolonged APTT. That occurs when the clinical notes provided suggest the patient is not known to be on heparin or any anticoagulant, but the APTT is prolonged, and then you have to do factor assays or various other tests to investigate that. But covering unexpectedly prolonged APTTs really is for another time, I think, because we have some very good solutions for that here. In fact, that's the basis of our work here at Haemotex, is trying to overcome this question. I had many of these problems when I was working in the lab myself, so I would like to talk about that in a separate talk later on. Okay, so that's probably enough for the time being. Thanks for watching.